Hey everyone, and welcome back to the Dr. Eric Fethke channel. My name is Jamie, and I'm back here, as always, with Dr. Eric Fethke. Eric, how are you?
I'm well, thank you. How you doing, Jamie?
I'm good, man. I'm excited to talk about something that is a little uncomfortable to talk about, to be honest, which
Mm.
is medical errors. So, the number of medical errors in the United States is astounding, even when you don't account for the fact so much money is spent. What the hell is going on?
Oh, I sometimes I think we try to over-explain that, and you're right. It's something when I tell my students that we may do as much harm as we do good in our current system. I'm not trying to scare them away from being a nurse or a doctor, but I'm just trying to let them understand that that's something that they have to factor into their decision making for their patients. Um, it's really gotten very complex. And some of it has to do, Jamie, with the fact that people are sicker. So the risks go up. It's definitely, we see a lot of that. We're doing more high intention, high intensive care kind of work. People are coming into the hospital settings are sicker than they were before because now many patients can be taken care of as outpatients. There's a good side to it. So things that we do in the hospital are more risky to begin with. So that raises the stakes right away. And so that factor is one component, and I think it's a significant component. But that being said, there are ways to minimize that issue as well. And people are working very hard on trying to do that from computer systems, from policies and protocols, emergency room systems, admission systems, things that happen in the operating room in that very complex setting in the ICU, double checks and all that stuff. People have worked on many different models to do this. Sometimes I wonder if the models become more important than the actual goal, though. I think they get overwhelming to administrate them, and people kind of get lost in what are we building a net for what? What are we trying to catch here? We're trying to catch mistakes before they happen. Oh, I'm tangled up in the net. I'm so confused. I forgot what we were doing this for. I still have to check this off and do this paperwork and whatever. And where's the patient? Again, I think sometimes we administratively get top heavy, even with our safety systems. So I think we can make those simpler. But that's the kind of explanation that maybe is the excuse. Things are getting more complex. But then there are a lot of mistakes that happen that really do happen in the handoff from those institutions back to the community, or vice versa, from the community to those institutions like hospitals and surgical facilities. And I think that's where there's a big potential for mistake is just in the communication. We all thought that the EMR, electronic medical record system, was going to make things more transparent, make less mistakes. Everybody would be sharing a common dialogue and record of the patient, and that would help. Well, that makes sense logically, but it's not happening. What happened in reality is that somebody put a firewall, literally decided for reasons that elude me to this day, some of them legal, liability, technical, financial, to not allow the records necessarily in your doctor's office to seamlessly go into that surgical facility, that hospital. Patients think, oh, my records are in the chart. Well, they used to be. I used to write a note, and that note, I would go back into the hospital later that day, and I'd see my note from my office in the chart. And that was the start of that admission. Everybody would refer to that. And it made a lot of sense to me because I knew the patient. I was sending them there. I knew them well. And it was really a nice transition into that setting. That's not happening. Those records do not transfer electronically in there. Many times they start from scratch. You turn around. I can't tell you how many of my colleagues pick up and say, how's my patient doing who I sent there this morning? And, oh, they're still in the ER, or we sent them off to this and that. And then the referring doctor, many of my colleagues are calling, can you believe what they did with them? That wasn't even why they were there. And off they go in other directions. And I think that that's a huge problem. The medications errors get transcribed improperly. They're not on this anymore. Well, why didn't the patient tell us? Because the patient's sick. Their family is stressed. It's my job clinician to clinician to tell you. And here you are, I've handed you off into another space and there's no continuity. So I think that is a big problem. Communication back and forth, leaving the hospital too. Oh, we're sending the baby home and they need this, and that. And we're sending them home on a Friday night. And we hope that somebody will be at the house to help with that. And the pharmacy will be open and da da da. Da. And all of a sudden, something as basic as the transition into the home setting with someone to help the family, say in a complex surgical case or even a basic infection. Now the floor drops when the family gets home. They're stressed. They thought they knew what they were doing and they just can't get the resources back at the community setting. I think that could be done so much better. And technologically we could do that. And then there's just the mistakes and errors when people go around seeing multiple clinicians and settings as an outpatient and kind of go shopping around. And therefore, the communication between these different doctors' offices, for example, aren't talking to each other. And a patient is on the same medication 3 times with a different name and doesn't realize they're overdosing on it or something very, very basic like this. I can go on, but there are so many logistic reasons why we're having far too far many errors, mistakes, and really many of them can be quite lethal.
Medicine is just too subtle a game to have communication errors. I've had an experience this week where I had 2 procedures, one of which needed to happen before the other one, it turned out. Because you couldn't do the second one, it was a risk if the first one happened first. But 2 different doctors and secretaries organized it. The order is flipped. I now can't have the second one for 6 weeks, and the diagnosis is delayed 6 weeks. What's the solve there? What's the solve in terms of communication errors due to the level of complexity?
I think the answer is much simpler than people, want to. I mean, when something seems so complicated and overwhelming, people just throw up their hands and assume that the solution is complicated. And I think that sometimes we just got to look at some of the commonalities, the core issue, the root cause, as they call it, in people who do analyses like this, like what's going on. Well, who's the center of all this? The patient. So why not empower them to be the one who controls and knows the information at all times? And not just because they're some mail courier that says, hey, I've got a piece of paper from my doctor. I was told to carry this to you before I drop dead. No, not, oh, I've got a chip or a file, or now I've got it embedded in my skin. God knows in the future, you can scan me and learn everything. Okay, maybe that might help, some technology like that. But again, that's where we're getting too much, emphasis on technology being the answer. It can help. It's a tool, but who's it for? It's for the patient. Why not empower the patient? Why not educate them? Why not make sure that they're where the buck stops in decision making and understanding what's going on? Educate them as much as possible to what's going on through the doctors and clinicians that they trust in the outpatient setting so that they speak with a voice that is as equal to the caretakers that they're going to in terms of whose voice matters. Meaning, I do know what's going on with my body. I do know why I'm here. I've had this discussion. I have my patients tell me that they run into the hospital or go into the hospital to do surgery for my heart patients, my kids. And one of the things I'm most proud of is that we have this crazy reputation where the nurses in multiple hospitals in New York City will say, oh, that's Dr. Fethke's patient. They know what's going on. They'll know. They got it. That's going to be an easy patient to take care of. They're informed. They're aware. They'll know what to answer. And they know they can reach Dr. Fethke if they have a question. And essentially, we've raised the standards for my patients just by having them come in, being part of their care in a much more proactive way. E-patient Dave talks about this on one of our episodes about, being participant in your care. And I think it's a great idea, but I've been doing this for years. And I think that if the patient walks into a setting like you and you're the point where you say, wait, aren't we supposed to do this first before we do that? Ah, you don't know what you're talking about. Actually, I do. And before you do anything, you need to stop. And if you don't trust me, get on the phone with my doctor. Okay. The person who knows me medically. But I'm telling you, I'm not doing that until you make sure, because I think that might be the wrong step. Once we get to the point where we believe we can get the patients, and I know we can, I've done it for decades, to that level, think about how many mistakes will go away.
Yeah, you're essentially cutting out the middlemen or women who are the multiple doctors, secretaries, nurses, all of whom have their own lens, their own bias, their own systems. It's unbelievably easy to imagine that you could have 5 nurses and doctors, all of whom are behaving according to the system that works for them and is
Right.
internally consistent, and how that just gets totally misinterpreted. You also mentioned the fact there's more medical errors is a little bit of a false positive in one way, because we're only doing more complicated things in house. Can you just expand on what the silver lining is there?
Well, I think that the idea that the sickest patients, the most intense procedures belong in settings that are best prepared to do them is as natural extension over time of some of the things we've talked about in the past, the technology of healthcare, but where we do it and where it's performed. How much can we do at home versus in a outpatient setting versus in a hospital? And the silver lining is that as we push the envelope, which we've done in pediatric cardiology historically, again, I mentioned in the opening of my book that, we would never have delved into heart surgery if somebody hadn't taken a chance with a child. Pediatric heart surgery was the beginning of the field. Well, there was a risk there, and the risk was a shared risk. It was a risk between the families and the clinicians. It wasn't me telling them, ordering them what to do. We realized that that shared risk had an upside. And therefore, what we did is we balanced that together as a team, families, patients, and doctors. And eventually others stepped into the mix, insurance companies and lawyers and hospital administrators, and they started weighing in. You can see how complicated that gets. Well, simplify this, make it based on the people, again, who made those initial decisions, but we push the envelope as we're doing in so many ways in these settings. Bring the patients together to be part of pushing that envelope. The silver lining is you can't get better. Technologically, you can't advance if you don't push the envelope. You will just do the status quo. And the status quo has maybe lower risks than pushing the envelope, but the outcome later on is not as good. So you never get where you're going. You never get to be as healthy. So sometimes in these very ill situations, whether it be cancers or surgeries or things, you do have to push the envelope. That's one of the things that many people in the United States have pioneered that approach, and we're kind of hesitant to do so. Other countries, are very good at that as well. And there is a little bit of a shared risk model that has to happen when you push the envelope, with the idea that the goal, the gain, the prize at the end is better care in the end, that you will be healthier. How do you balance that out with risk? It's got to be a shared decision. It can't be one side, and it can't be shared with 20 people. It has to be shared with the most important stakeholders, the patient and their clinicians.
And that's where public health decisions and private healthcare decisions don't always merge. Because what
That's
would be an overly risky policy across 350 million people may be a very intelligent decision across one individual.
Yes. And that's where you balance the common good for the individual good. That's the dynamic of a free society. I mean, that's why healthcare in a democracy is not separate from its democracy. we have to determine not only what's best for me at this moment, or maybe in a few years, the selfish side of the coin, with what's good for my family, my community, and my nation as a whole. And making that decision when I may have to sacrifice something and give that balance up. That's the coin we're fighting all the time, whether we're talking funding, whether we're talking vaccines, whether we're talking policies, whether we're talking, about distribution of resources and how we do this. This is uniquely going to be an American issue for us. Every nation, every community has to wrestle with that whole dynamic. How do we balance the common good for the individual good? Because ultimately, if I make decisions and we make it all together in a democracy for the common good, if we again play it safe, then we may all fail there. If we basically say, look, and I think we're at a point in our history where we have to do this, we might have to do a little bit of a revolutionary move. We may have to break the ceiling. We may have to pop this bubble and really take it to the next level. Yes, we in our community, there's a model here that's done that. Maybe we can expand it. Maybe we can adopt it. Maybe it can be a national thing, but it has to be a constant partnership to advance and push that we all share the risk from.
Dr. Fethke, thank you for being here.
Yeah, it's an honor to have this discussion. Thank you very much for inviting me, and I hope that everyone who's out there can contribute. And if they have any ideas, I'd love to hear them, because these discussions belong to all of us and are very important.